Today I shall be talking about supracondylar fracture of humerus. Mechanism of injury. In this there is extension type, flexion type. Mostly 97% is extension type, it is very common, and less than 3% is flexion type. Extension type is due to fall on outstretched hand, and flexion type is due to fall with joint in flexion. Displacement in extension type. It may be posterior, medial, internal rotation. Classification or in extension type, Gartland classification 1, 2 and 3. In 1, undisplaced fracture. 2, angulated fracture with intact posterior cortex. A fracture is angulated but with intact posterior cortex. And 2A, there is only angulation, but 2B, there is angulation plus malrotation. In 3, type 3, there is completely displaced fracture. Type 3A, posterior medially displaced, and 3B, posterior lateral displaced. On clinical feature, there will be pain, swollen elbow, inability to move elbow, and deformity. There will be posterior displacement, associated vessel and nerve injury. On examination, there will be short arm with normal forearm length because fracture is in the arm, gross swelling and tenderness. Both active and passive movements of the elbow is decreased. 3 bony point relation is unaltered because fracture is above epicondyles, lateral epicondyle, medial epicondyle and olecranon. This is the 3 bony point and the fracture is above condyles. Talking about imaging, in lateral view, there will be loss of teardrop sign. Normally teardrop sign is seen in lateral view due to superimposition of olecranon fossa and the coronoid fossa. But in supracondylar fracture of the humerus, shadow is formed and coronoid fossa comes anteriorly. So loss of teardrop sign. Fat pad sign. Due to olecranon fat pad pushed forward by the fracture hematoma, triangular lucency is seen, which is known as fat pad sign. Fish tail sign. There will be rotation of the distal fragment due to which anterior border of the proximal fragment looks like fish tail. Anterior humeral line. Normally, the line through anterior cortex of the humerus passes through the middle third of the capitulum, but in this, the line through the anterior cortex of the humerus passes through the anterior third or front of the capitulum. Shaft condyle angle. Normally it is 40 degree. It is the angle made between the shaft and the lateral condyle and is less than 40 degree, then it is fracture. On anterior-posterior view, we see the Bowman's angle. This is the angle between humeral axis and capital physis, which is normally less than 80 degree, but in supracondylar fracture of the humerus, this angle is increased. Now talking about the treatment, if the fracture is undisplaced, then we do immobilization with elbow slab with 90 degree elbow flexion for 3 weeks, then we can mobilize the joint. In type 2A fracture, which is posteriorly angulated fracture, closed reduction is performed with traction and counter traction for 2 to 3 minutes, traction with elbow in 30 to 40 degree of flexion. While in traction, the elbow is gradually extended and forearm is fully supinated. Flexion in traction. Upper arm is grasped by the other hand, placing finger over the biceps and thumb over the olecranon. The elbow is now flexed slowly using the hand with which traction is being applied. Pressure over olecranon. While above posture is done, thumb presses the olecranon and the distal fragment forward, maintaining traction. If it is possible to flex the elbow more than 90 degree, the fragments are locked and posterior slab is applied for 3 weeks and X-ray is done to rule out slip, then plaster is removed. If it is not possible to flex the elbow beyond 90 degree, then the procedure should be repeated. Now in type 2B and 3, which is angulated and malrotated and completely displaced, reduction as above. In the type 2A, under general anesthesia, percutaneous K-wire is used to fix the joint. Open reduction is done for the fracture which cannot be reduced by closed reduction, and in open fracture which is associated with vascular injury. And continuous traction is given for the patient which presents late with excessive swelling, for which Smith's traction through olecranon or Dunlop's traction below skin traction is used. Talking about the complications, immediate complication is most commonly nerve get injured, which is the anterior interosseous nerve, which is the branch of the median nerve. Arterial injury, brachial arterial injury. And early complication, there will be compartment syndrome, In late complication, there will be malunion due to which cubitus varus deformity will occur, which is also called gone-stock deformity. In cubitus varus, apex is away from the midline. This is the trunk and apex is away from the midline. And when demonstrated with abducted arm, this looks like gone-stock. So it is called gone-stock deformity. And it also causes elbow stiffness. Myositis ossificans occurs, in which there is ossification of muscle. Volkmann ischemic contracture, in which there is permanent flexion contraction of hand at wrist and fingers due to ischemia. Thank you.